Hello, my name is Tariq Adar, and today we're going to review the gastrointestinal physiology by looking at different clinical cases and whatnot. I think it's good to learn GI physiology with what the pathophysiology is in mind. I think it allows for a more robust integration of that information. So we're going to start with the functional anatomy, the physiology and drainage, and we're going to talk a little bit about the neurohormonal mechanisms. The laser pointer. All right. So as you can see in the small intestine, you have villi and crypts, whereas in the colon, you have crypts. That's sort of one of the first things I want to draw attention to. And in a little bit, we're going to look at the overall structure of the GI tract. But first, I want to start with the very basic histology of villi and crypts in the intestine, in the small intestine, and then only crypts in the colon. Why am I bringing this up? Well, if you see tissue that has villi and crypts in places outside of the small intestine, you want to consider metaplasia. So that's called metaplasia, and it's specifically called intestinal metaplasia, and it has this villous appearance. And this can happen in the context of Barrett's esophagus, which is when acid refluxing into the esophagus causes damage to the member. There's squamous tissue usually in the esophagus. So as you hit it with acid, that squamous cell gets damaged. Like, I don't have the means to defend myself. Maybe I should change into a cell type that can. So it becomes like mucus secreting intestinal glands. And that's metaplasia, and that's Barrett's esophagus. With time, now most people with reflux don't get metaplasia. Most people with metaplasia don't get Barrett's esophagus, which is dysplasia. Okay, and most people with dysplasia don't get adenocarcinoma. That being said, it is an important risk factor, and these patients require surveillance. Okay, so that's the kind of the importance of recognizing the difference between the architecture of the small intestine, the large intestine, and how you shouldn't see that architecture in other tissues. And then in the colon, you have your crypts. These crypts will be the site of abscesses and Crohn's disease. Now, stem cells in general come from the crypts, and they will migrate. Okay, so stem cells come from the crypts, and then they migrate. In the stomach, they might migrate downwards rather than upwards to become the chief cells and all those other cells. But I don't think that's particularly important for you to know. The bigger point is that there's stem cells being secreted, or not secreted, being produced, and their life cycle is like half a week. So there's constant turnover of the cells in the GI tract. And whenever you have increased cell turnover, you have a risk of cancer. That's why so many tumors can arise, particularly in the large intestine with age. Which is true of most other tissues that experience environmental insults. Most of those tissues can experience cancer. So, for example, the lungs, if they get exposed to enough carcinogens from their environment, can give rise to lung cancer. In the GI tract, you can get GI cancer, etc. And here we see the different layers of the GI system. So you have the epithelium, which can look different in different tissues, with a basement membrane, a lamina propria, and a muscularis. So those layers make up the mucosa. These are the mucosal layers. The submucosa is sort of more stromal and lies underneath the mucosa. And then you have your muscularis propria, which has circular muscle, a plexus, a myenteric plexus underneath it, and then a longitudinal muscle layer. And what I want you to imagine is that, imagine this is a tube of intestine. The longitudinal muscle contracts like this and sort of squeezes longitudinally along the length, right? But how does food propel? It's just all the longitudinal contraction does is make the tube shorter. So it's actually the circular muscle which sort of pinches. So that pinching of the circular muscle and shortening from the longitudinal muscle is what propels food forward. So rather than just going back and forth like this, you have this pinching and forward, pinch and forward. And that's done under the influence of, they're called motor complexes, MMCs, but that's beyond the scope for right now. So and here you have the serosa. Now, I will say there are tissues that don't have a serosa. And those tissues, if you were to get cancer of them, they invade very easily because there's no serosa holding them holding them back, or adventitia holding them back. That being said, we want to consider this structure because it's kind of relevant when we think about Crohn's versus ulcerative colitis. So in Crohn's disease, I'm going to use red for Crohn's, all three layers are affected. Okay, in Crohn's, you get transmural, so they're both autoimmune diseases of the GI tract. I'm not going to belabor them too much. I'm trying to point out the importance in the histology here. So in Crohn's disease, you have transmural inflammation of the GI tract as a result of caseating granulomas. Okay, you might remember that phrase, caseating granulomas. And because it's transmural, it affects all three layers. It's going to affect your mucosa, it's going to affect your submucosa, and it's going to affect your muscularis propria. So you can get perforation, abscess, fistula, because what happens is, let's say this is the GI tube, and you have your three layers. In Crohn's disease, all the layers are affected, so you can get leakage of GI contents here. And let's say this is one loop of bowel affected by Crohn's, right? So this part here is, let's say this is affected by Crohn's. What can happen, because it's transmural and involves all three layers can be damaged and stuff will start to leak out. And if it's connected to bowel, you can get enteroenteric fistula. So that's entero for intestine, enteric for another intestine. So from intestine to intestine, you can get this leakage and communication between this fistula or communication. Fistula is a communication, a pathologic communication between two loops of bowel. And that would be the enteric fistula. I'm not going to go too deep into this. There's other organs that can be involved. Skin can be involved. The anus can be involved. So there's a GI. So Crohn's can affect anywhere from the mouth to the anus. And the other thing, big thing in Crohn's, besides the fistulizing disease, is stricture, because it's affecting, again, all three layers. It can cause stricture to form. Okay, so it's like you have normal bowel, and then you have this thickening. And what you might get, and radiologically you need this to make the diagnosis, you can get dilation of the bowel proximal. So this is the bowel proximal. You can get dilation of the bowel proximal to the stenosis, and then decompression of the bowel after stenosis. So in other words, this is the stricture, and the food builds up here, and you'll also get what's called fecalization of the small bowel. So normally the small bowel, and this isn't the exact color of it, on CT scan will just have like a consistency that's homogeneous. Okay, maybe a little more or less like this, except gray. In fecalization, what happens, and this is what usually stuff looks like in the colon, you just see like a bunch of stool-like structures in the small bowel, and that happens proximal to the stricture. And the reason why it does that is because stuff is sitting around in there, it's not moving smoothly, etc. Everything's dilating. So you want to consider that, okay, with Crohn's. Because all three layers are affected, you get abscesses, you get fistulas, and you get stricture formation. All right, versus Crohn's disease, so I'll do that in blue. In Crohn's disease, it's usually just the mucosa and the submucosa that's affected, but not the muscularis. So because remember, the muscularis gives it elasticity. Because it can become elastic, and again, the hallmark of ulcerative colitis is crypt abscesses. Crypt abscesses. You remember those crypts we looked at? And unlike Crohn's, a crypt abscesses, ulcerative colitis usually starts in the rectum with the formation of abscesses and colitis and moves proximally to slowly involve the rest of the colon. Crohn's, again, anywhere from mouth to anus, it could start anywhere, it can skip around. That being said, where it starts tends to be where it stays with Crohn's. That's not always the case, but where it starts tends to be where it stays or where it gets worse. With ulcerative colitis, you start at the rectum and slowly progress. Okay, and because your muscularis is intact, you have all this inflammation, all this stuff, etc., blah blah blah, and because the muscularis is intact, it can actually dilate. The colon can dilate. And when it dilates, you can get a very severe form of fulminant ulcerative colitis called toxic megacolon. This can happen from a number of other things as well, such as Clostridium difficile toxin, but that's beyond the scope of this lecture. But in toxic megacolon, because the mucosa and submucosa are what's being affected, and the muscularis is intact, you get this big dilation of the bowel, right? So let's say normally the bowel should be like this. You get this big dilation of the bowel. Yeah. And if this was a radiology lecture, I would have included images of all this, but it's not, and this is more targeted towards first and second year med students at most. Um, so I'm trying to keep this relatively simple and bare bones. Um, so the other thing with both ulcerative and Crohn's is that they have extra intestinal manifestations, especially with ulcerative colitis. You want to think of primary sclerosing cholangitis, which is stricture of the bile duct, but we'll talk about that later. And then over here we have just sort of, we're going to play a little matching game and say which organs do which. So the chopper is the mouth, right? And actually what's not labeled here is the esophagus. So I want to kind of think of this like the transport, because this is equally important, even though it's not labeled. And that'll be the esophagus. Okay. So obviously, when is the chopper dysfunctional? If you don't have teeth, etc., that sort of thing. The dysfunctions of the esophagus, some of them can be motility. So that would be like achalasia. You can have motility disorders of the esophagus, and you can have structural disorders of the esophagus, right? So the motility can be achalasia, which is like neural and like other causes, etc. For I don't want to get too deep into it, but and some of the structural causes can include cancer, your adenocarcinomas and your squamous carcinomas. Remember, we talked about Barrett's esophagus and all that stuff. So the transformation, so the adenocarcinomas, and I'll code that in bright red. Adenocarcinoma tends to involve sort of like the last part of the esophagus, last 2/3. I think the upper 1/3 is mostly squamous cell. Okay, and as you can imagine, people get more obese and more people have reflux and more people have Barrett's esophagus, because obesity is a risk factor for all that stuff. We've seen and will continue to expect a transition from less deaths from squamous cell carcinoma and less cases of squamous cell carcinoma, and an increase in the amount of adenocarcinoma. That just makes sense, because people's diets are getting unhealthier, people are becoming more overweight, people are having more GERD as a result of being overweight and all that stuff. Um, and that's causing more Barrett's esophagus and more dysplasia and eventually more cancer. There is also this nitrosamine containing compounds in hot teas have a risk for squamous cell carcinoma. But again, this is all very beyond the point. We're just trying to look at the anatomy here and what can go wrong when we think about the functional anatomy. So that's the key word here. We're talking about functional anatomy. This is not a anatomy lecture. We're going to point out all the different anatomic structures. No, we're talking about how do the structures that are most important inform our discussion of the GI tract's function and what can go wrong with that function. So as we said, the esophagus, its motility and its structural defects, and it's not all dysphagia is cancer, and not all cancer is dysphagia. So I just want to put that out there. So your structure, it could be malignant or neoplastic, right? But you also want to think of webs. You've got your classic Plummer-Vinson syndrome. It's iron deficiency anemia, and you form these like web-like structures. When you treat the iron deficiency anemia, the webs tend to go away. And then you have Schatzki's rings, eosinophilic esophagitis, like a whole number of things that can mess with, with swallow function. And then you get to your blender, your acid sterilizer, your reservoir. This right here, this is your stomach, okay? And this is why this organ is the target of so many different kinds of bariatric surgeries, whether it's sleeve or Roux-en-Y. We're not going to get into that in this lecture. I'm going to have an entire lecture dedicated to the esophagus and the stomach, and some of the procedures and how they affect the anatomy and clinically what we need to be careful of. That there's a whole other lecture coming for that. But yeah, so the stomach is involved in these functions, and some things that can go wrong. You can have too much acid, so that can happen with Zollinger-Ellison syndrome, which we'll talk about later. Um, if you think about its role as a reservoir, you can target that in obesity with those procedures I mentioned earlier. When you think about it as something that's supposed to sterilize, another thing I want you to think about is if you give an antacid, you increase the risk of infection, um, because normally that acid would kill bugs, but if you're decreasing your stomach acid, there's a susceptibility. And there's also some important digestive function of the stomach. It does not digest things directly. Like it can break things down, but it doesn't quite absorb them. So it does digest. It just doesn't have absorptive capacities, for protein breakdown, for intrinsic factor, which is secreted by the parietal cells, and autoimmune destruction of those parietal cells causes what do you call it? Pernicious anemia. So there's a lot of things that goes on over here. And I think acid is required to activate the first part of that binding process, but I'm not 100% sure, so I'm not going to go into it right now. So we're done with the stomach, and then we move into the reaction vessel, which is really a duodenum. All right. So this is the duodenum. And then duodenum is going to bring in a couple things. First of all, the detergent supplier. This is the gallbladder, where bile is stored, and patients without a gallbladder, usually the bile will just go directly through the bile duct in. So basically you have the gallbladder here, and you have the bile duct, and then you have your pancreas, whatever, and you have your pancreatic duct. And these two will like join together in this part of the duodenum, part of the small intestine, called the ampulla of Vater. And so what can happen is you can get a gallstone right here, and that can both obstruct the pancreas and cause pancreatitis, or it can cause obstruction of the biliary system and cause jaundice. Or the pancreas can kind of, let's say you have a tumor here in the head of the pancreas where the duct passes, it can grow and compress the bile duct and actually cause an increase in the gallbladder. So that painless jaundice with a palpable gallbladder is called a Courvoisier sign. I'm totally going to spell it wrong. Courvoisier sign. I probably spelled that wrong. And that's a palpable gallbladder with jaundice. So what the gallbladder does is that it supplies, well, the liver makes, right, the liver over here, the gallbladder just sort of sits on the liver, and there's a duct that comes down, and then there's a duct coming from the gallbladder, and then those ducts combine to give rise to the common bile duct here. And so basically it's the liver that makes the bile and the gallbladder stores it. There's like this, you want to think of it kind of like if you ever squeezed one of those sacs and then when you let go, it just sort of opens and sucks the air inside. So the gallbladder isn't full, it's like all contracted, and there's like this negative pressure suction force, and it'll fill with bile automatically. And then when you're eating a meal, you'll get the release of cholecystokinin, chole meaning bile, cyst meaning sac, and the gallbladder is just a sac of bile, kinin meaning movement protein. So cholecystokinin is the movement protein of the bile sac or the gallbladder. It has some other functions as well, but we're going to focus on the gallbladder function for now. So that cholecystokinin should cause the gallbladder to excrete its bile. All right. And what those bile salts do is they emulsify. That's why it's called the detergent supplier. More accurately, the bile salts emulsify. And it kind of causes the mixing. It causes like the mixing of it makes, how do I explain this? It's like soap bubbles. It kind of creates this like soap, kind of like the concept of a soap bubble, where it allows hydrophobic and hydrophilic things to mix a bit. And that's very important for the absorption of the fat soluble vitamins because they have to dissolve in these bile salts and lipids. So the lipids, the fat soluble vitamins, all of them sort of merge with the bile salts and they get absorbed together by chylomicrons. But these emulsified vitamins are the ADEC vitamins. All right, so vitamin E, which is important antioxidants, vitamin K, which is very important for coagulation, vitamin D, which is important for bone formation, and vitamin A, which is very important for night vision, for immunity, and for the differentiation of skin cells into and most mucosal cells into their squamous form. The differentiation of squamous cells depends on vitamin A. So yeah, so a lot can go wrong if you don't have functional bile salts. And usually the patient will report clay-colored stools because it's the bile salts that give stool its color. So you'll just have these like gray, discolored stools. Usually because the fats, without the gallbladder fats poorly absorbed, not without bile salts, fats are poorly absorbed, they might float. They'll definitely be floaty if you have a problem with the pancreas, which brings us to the next one. So our enzyme supplier slash neutralizer, that's the pancreas. Okay. Um, for example, in patients with chronic pancreatitis, you might need to supplement enzyme because they've so basically a lot of one of the biggest risk factors for chronic pancreatitis is alcohol use, excessive alcohol use, and in these patients, they can get pain if unless you supplement them with pancreatic supplements. Like they get this cramping. Aside from the chronic pancreatitis, they also just have pancreatic insufficiency, and that pancreatic insufficiency presents as like these cramping pains. They can't digest properly, so you can give them Creon, which I believe is the I could have this wrong in my head, so please fact check me. I'm just off the cuff saying this. I think Creon is a pancreatic enzyme supplement that can help with those symptoms. So that's kind of some of the things that can go wrong with the pancreas. There's a lot that can go on with the pancreas, so we'll have probably a separate video on the pancreas at some point. And again, you have your catalytic and absorptive surface, and that's just your intestines. Your residue combustor, desiccator, and pelleter, that's your large intestine. You're making the poop, and then you can consider like the rectum, the anus as the emission control device, particularly the sphincter. Now, if you have a tight internal sphincter, that can cause constipation, hemorrhoids, anal fissures, because you have to strain more um, to pass a bowel movement. It's an inappropriate tightness of the internal sphincter. Usually the external and internal sphincter should like open together and close together, but in some people the internal sphincter can stay tight. And then over here, we have the parotid glands, the mouth, and the salivary glands. This is a sublingual gland. This is submandibular. This is the parotid. Over here we have Stensen's duct. And why am I mentioning these things? Okay, because these things can get messed with. So for example, some facial tumors, facial nerve tumors, schwannomas, can compress Stensen's duct, and that can cause some, adenitis or inflammation of the gland because whenever you compress something, you cause inflammation. But that's very rare. Admittedly, that's very rare. What's usually involved is the submandibular gland here. There's a number of risk factors for infection of this gland. The two most important ones are immunocompromise. I would say three really important ones: poor oral hygiene, immunocompromise, and an obstructing stone. So what's an obstructing stone? So you can get stones that form in the salivary glands, and dehydration can cause it, critical illness can cause it. There's a whole gamut of things that can do it. But the bigger point I'm trying to make here is that in this duct, it's called Wharton's duct. This lower one here, is Wharton's duct. This is Stensen's duct. So in Wharton's duct, you can get an obstructing stone. And then let's say the patient has diabetes or is immunocompromised or has poor oral hygiene, like some collection of risk factors, you can get infection of this gland. That's called sialadenitis. All right. Normally, saliva contains enzymes and lysozymes, so it can break down what do you call it? It can break down bugs. So that's why a lot of patients with Sjogren's. So Sjogren's is an autoimmune disease of the glands, and you kind of get dry mouth, dry eyes, etc. But in Sjogren's, you get decreased lysosomes because you're making less saliva because you have dry mouth, and you have poor oral hygiene as a result. You get cavities. You get cavities more easily because you don't have as much lysozyme coating the mouth and breaking down bacteria. So that's why that's important. And I already talked about the stones and Wharton's duct. And usually, if it's just a stone, you do conservative management. If you have separative disease, obviously that it's going to require some kind of intervention. But for stones, you can usually just put like a warm compress, massage the area, NSAIDs for the pain, and it'll usually pass on its own. And then we can see here the rest of the anatomy. You have the lower esophageal sphincter, the liver, the gallbladder. You can see here how there's two hepatic ducts. There's a left and right bile duct, and they form proper hepatic duct, and there's a gallbladder and a cystic duct, and they travel together as the common bile duct. And then there's a pancreatic duct with the pancreatic stuff. So the gallbladder stuff, the pancreatic stuff, it all combines and inserts at the opula of Vater in the duodenum. So this is the first part of the duodenum, the second part of the duodenum, the third part of the duodenum, and then the fourth. All right. And then you have what's not seen here because it's behind all this stuff is the transition from duodenum to jejunum, and then you just go from jejunum to ileum. And then the ileum connects to the cecum, but with the ileocecal valve. And please note the presence of the appendix next to the ileocecal valve, especially for you budding radiologists. Notice that it can be here. Sometimes depending on the position of the cecum, you can have an appendix that's all the way up here. So not all right lower quadrant pain is appendicitis, and not all appendicitis is right lower quadrant pain. And what happens in appendicitis? Well, there's a number of things, but one of the more common things that can happen is you get a fecalith or the stool stone, and it blocks the appendix. And as you've seen in all the other things we've talked about, when you get blockage, you get stasis, and when you get stasis, you get increased intraluminal pressures and sometimes edema, or you can get infection and it just gets nasty, and then the appendix can actually perforate and cause peritonitis or septic shock. I mean, things can get really bad once that appendix goes boom. But usually want to catch it before then. And what a lot of surgeons would like to do, depending on how bad the inflammation is or how bad it looks, they might want to give antibiotics and wait for the area to cool down before they go in and operate. Because I want you to think of inflammation, it kind of destroys the integrity of tissue. So you don't always want to operate right away. So it's important if you're a radiologist, for example, to be able to report certain findings like the appendix is ruptured. Well, if the appendix is ruptured, you want to give broad spectrum antibiotics, right? You want your medicine team to know that. Now they might want to treat with antibiotics anyways, but what you find and what you dictate could change the management of the patient. If appendicitis looks sort of limited, like there hasn't been a severe complication yet, the area might be safe to go in and resect. So you won't have to do an interval appendectomy. An interval appendectomy is like, okay, this area looks really hot right now. If we go in, we might make the problem worse. So let's hit it with really hard antibiotics and just treat whatever complication may arise, and then we can go in and remove everything, debride later if necessary. If the appendix ruptures, it's kind of hard to kind of bring all that stuff together because inflammation is so bad. But it can be done. I mean, it depends on what you see on the imaging. But I ramble. So that's the appendix, that's the ileocecal valve. And then as you come up, you have your right ascending colon. You can see these pouching are called haustra. That's kind of what differentiates large intestine from small intestine. It's these characteristic haustra. And then you have your transverse colon, your descending colon, and your anus. So real quickly, I want to draw your attention to a few parts. This is a watershed region between the IMA and the SMA. And then this is a watershed region between the, what do you call it? The inferior mesenteric artery and the superior rectal artery. What was I going to do? Oh, right. I want to show you the vasculature, right? So you have your celiac trunk up. So let's say this is the aorta. Your celiac trunk comes off here, and you get your hepatic artery, which gives rise to the gastroduodenal artery, and then it continues to give off the rest of your hepatic arteries. I'm not going to draw all of them because that's not what we're talking about right now. You have your left gastric that goes up, and then your splenic, and then there's variations of the celiac trunk. So I want you to keep in mind, not everything you learn in the textbook is how your patients are going to show, especially if you're going to be a surgeon or a radiologist. Keep in mind that classic anatomy is what is taught in schools, and there are variants, though you don't really need to learn the variants until you're You don't need to learn most, the vast majority of the variants until you're in your training. And then you have your splenic artery here. Now, right underneath the celiac artery comes off the superior mesenteric artery, right? And then the renal arteries come off underneath it, blah, 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 all that wonderful stuff, okay? Now, the superior mesenteric artery gives rise to the, and I'm really hoping I remember these correctly, it's the ileocolic, the right colic, and the middle colic artery. Okay, so we're not going to worry too much about these and their different offshoots. What I want to pay attention to is the middle colic artery, because it kind of, not to be confused with the middle cerebral artery, even though I called it MCA, because this is sort of going to give off vessels that perfuse here. And then lower on the aorta, the IMA is going to come off, the inferior mesenteric artery. It's a much smaller vessel than the SMA. It's difficult to see on imaging. And the IMA is going to give off a couple vessels. The one I want to bring attention to is the left colic artery, which is going to come up here, and then it's going to give off its thing. And this area here, so they'll anastomose. The middle colic and the left colic anastomose, or they form these connections, and these connections give rise to the marginal artery of Drummond. Now, this is a watershed region. Why am I bringing all this up? Because this is called a watershed region. And this watershed region is susceptible to infarction. Let's say someone has poor forward flow. So let's say they've got congestive heart disease. They went into shock for some reason, MI. Maybe they had AFib and the SMA got occluded. This area can undergo ischemic colitis. All right. Other areas can too, but this area is particularly susceptible because it's a watershed region. Watershed refers to wherever there's poor collateral flow. So it's like where there's not a lot of overlaps. Over here, there's a lot of overlap between vessels. Over here, there's a lot of overlap. But this region is supplied by a very far away middle colic artery and a relatively far away left colic artery. So disruption of either one of those could cause ischemia, or both of those. In the case of poor forward flow, can cause ischemic colitis, which is usually just like bloody stools. We talked about the anus, internal, external sphincters already. We talked about these watershed regions of the colon. And again, Crohn's disease could affect here, anywhere. Crohn's affects anywhere from the mouth to the anus. But ulcerative colitis is going to start at the rectum, skips the anus, and it'll work its way upwards until it involves the whole colon. Something important to keep in mind is that patients with ulcerative colitis, they need to be screened for colon cancer. Because remember, we said the GI, just to tie things back to the second or third slide, the GI tract is constantly turning over cells. In the context of inflammation, that's worse. And there's cell damage and growth and repair and so many cycles of crap going on with inflammation and turnover that ulcerative colitis patients 8 years after the diagnosis will require a surveillance colonoscopy to look for cancer. These Crohn's disease patients also have increased cancer risk, but ulcerative colitis patients more so. And the last concept I want to talk about on this slide is that blockage of any part of the GI tract will lead to obstruction and backup proximal to the site of the obstruction. I talked about that earlier. And some examples could be adenocarcinoma, so if the colon cancer is obstructing the colon, stricture formation, Crohn's disease, which we've already talked about. And over here, I just wanted to show you more of the salivary glands. This kind of gets skipped over in med school usually, at least that was my experience. So I kind of wanted to point things out to you. So you have your tongue, your sublingual gland, and your submandibular gland. See this duct coming out and through. So the sublingual gland can either deposit its secretions directly into the floor of the mouth or through the Wharton's duct coming from the submandibular gland. And so I kind of just want you to notice where everything is sitting. And then you have your masseter muscle over here, and you have the parotid gland and the duct sort of coming over. So you can see this is kind of in a region where it's compressible. Remember, the facial nerve also travels through the parotid gland. So some of those problems can go hand in hand. You have your sternocleidomastoid here. The big thing I wanted to point out though is Stenson's duct, the parotid gland, the course it has to take over the masseter, the fact that the facial nerve travels through here as well to innervate the masseter and the buccinator, and all those chewing muscles require facial nerve innervation, which is cranial nerve 7. And then you have your submandibular gland with its duct. Wharton's duct, like I cannot emphasize that enough. And bicarb is made in a lot of parts of the digestive system, especially the pancreas. And this is just a concept I want to introduce. I'm not going to beat the bush on, I'm not going to beat a dead horse on cystic fibrosis. But this bicarb is required, one, to neutralize stomach acid, and it also prevents the thickening of secretions. So remember, water goes with the electrolytes are, and bicarb is an electrolyte. So that pumping of this nonstop pumping of bicarb and chloride, if this CFTR gene is knocked out, you don't get this function anymore, the SLC26A6. You don't need to know SLC26A6. You do need to know CFTR, that's cystic fibrosis transductance regulator, especially the delta F506 variant is the main cause of cystic fibrosis. It tends to affect Caucasian people. And if you can't secrete bicarb and you have this disruption of chloride bicarb exchange, so basically you secrete chloride, and the secretion of chloride allows the symport of bicarb. And then when you don't have bicarb, you get thickened secretions. And you have trouble clearing them from the lung, and that's why you get a lot of the lung stuff. But you also get pancreatic insufficiency because your pancreatic enzymes can't really smoothly drain into the ampulla vater. So they get pancreatic insufficiency. So you're gonna need to supplement them on those ADEC vitamins. Remember, the fat-soluble vitamins. Without pancreatic enzymes, you don't break down fat. You don't break down fat. You don't get the fat. The vitamins can't be absorbed with the fat. So that's important. And then you have Hirschsprung and Chagas disease. Hirschsprung is when the stem cells fail to migrate into these plexusi. No idea what the plural of that one is. But the point is, these plexus nerves require they're stem cells that have to migrate downwards. So they start all the way up at the neural crest. If you remember your embryonic development, you think about your little what's it called? Not the blastocyst. After gastrulation, you have your 3 layers, right? And you have your ectoderm layer, and then it gives off the neural crest cells that are going to migrate along their pathways. In Hirschsprung disease, the neural crest cells fail to make it all the way down, so you don't get contraction of the bowel, and it presents as meconium ileus. Meconium is the first stool of the newborn, and they'll get constipated and they won't pass that meconium. What will happen though is when you do the digital rectal exam, you might get, it's called the squirt sign. Gross. I know, gross, but it's the squirt sign, and the poop squirts. And you would diagnose it. You can do a barium enema, which is both therapeutic and diagnostic, or barium air enema, water air enema. The point is, you want to, oh man, no, you don't do the, you might do an enema to clear everything out. But what I'm thinking of when saying barium enema, I'm thinking of intussusception, which is when the bowel telescopes into other bowels. So you remember that ileocecal valve we were talking about, where the ileum goes into the cecum? What happens is that that part of the bowel can sometimes slip in, like the ileum can kind of slip in. Intussusception can happen in other parts of the GI tract, but it can self-resolve usually by when you bring the infant's knees close to their stomach and the bowel will detelescope. The problem with the ileocecal valve is that it's very tight. So once the bowel sort of not herniates, but telescopes through it, it can't come back out. So intussusception involving the ileocecal valve will not resolve on its own and requires an enema, which is both diagnostic and therapeutic. So I was crossing wires there. But Hirschsprung disease is constipation and meconium ileus because you don't have neural crest cell migration. So there's no contraction. And because there's no contraction, the stool's just sitting there. When you put your finger in and you decompress it, the stool just sort of squirts out, shoots out, and that's your squirt sign. Chagas disease is similar. You also get a megacolon. But the Chagas disease megacolon is because the parasites in Trypanosoma cruzi, and just to summarize, just go back to Hirschsprung for a second. That barium enema being both therapeutic and diagnostic, no, that's intussusception. I was crossing wires, so please don't stick that in your heads right now. So Trypanosoma cruzi is a parasite carried by the kissing bug that's endemic to South America, Cuba, and it's going to be endemic to Florida at some point. I expect it to make its way up here. But Trypanosoma cruzi, basically the parasites destroy these nerves, and that causes big dilation of the colon. Now, Chagas can also affect the heart and cause dilated cardiomyopathy. So when you think of Chagas, you want to think of as, I don't know if you guys have ever heard the Divine Intervention podcast, and he says big problems, big hearts, big colon. You know, you get dilated cardiomyopathy, you get what do you call it? You get megacolon, et cetera, et cetera. There's some other things as well, but we're not going to go too deep into it. But again, I just want to highlight here, notice that you have the mesentery. So the mesentery is this fat that the bowels are sort of, how do I phrase this? The bowels are not ensnared, are suspended in. So the bowels are sort of suspended in this mesentery. And you can see here you have these perivascular nerves that come in through the mesentery, and they give rise to these plexuses. Plexuses, who knows? All right. That's important for muscle contraction. So problem with those, let's say in Hirschsprung disease, where they're not going to migrate all the way down to the colon, or in Chagas disease, where they're going to be damaged. You can also get Chagas disease in the esophagus. So you can have problems in the colon. You can also get dilation of the esophagus. So big heart, big esophagus, big colon. I think that covers most of it. And then, so basically nutrients, special centers. So in other words, nutrients both through stimulating your executive function and through, the enteric nervous system and its inbuilt mechanisms can cause stimulation of these organs and increase secretions and motility. And then there's crosstalk between the higher centers of the brain and the enteric nervous system, which is tons of neurons. There's tons of neurons in your GI tract. It's like almost like your third nervous system. You have your autonomic nervous system, your voluntary nervous system, and then you have your enteric nervous system. And these two centers communicate through the vagus nerve. So your mood influences your bowel function can influence your mood, and this is sort of the pathway by which it happens. That being said, motility can be affected, particularly in diabetic gastroparesis. So you get damage to the nerves, and it happens, a lot of nerves get damaged in diabetes. A lot of the autonomic nerves sustain damage. In this particular case, it's damage to the nerves related to these reflexes, due to elevated sugar levels, and you get disturbances in vagal tone, and you get decreased mobility. That's diabetic gastroparesis, although we have been seeing it more often because of Ozempic, because the GLP-1 agonists, one of their side effects is gastroparesis, and it can be permanent, which isn't the worst thing in the world because it makes you not tolerate food and throw up, but the problem is you have a lot of young people on this stuff, and that presents a problem as they age. And you can see here just what the normal hormonal expression profile is. You see the colon shouldn't express anything. So if you have colon expressing things, then you have a problem. And epithelial tumors can aberrantly express some of these hormones. Colon normally doesn't. Carcinoids secrete secrete serotonin. And the tumors in the later part of the GI tract tend to cause more obstructive symptoms. In the early GI tract and the lungs, you get carcinoid syndrome. That's because they make serotonin. And we're going to talk a little about that in a second. There's a reason why the early GI tract and the lungs cause this like flushing of the face and skin. And this is dry flushing. You're not sweaty. You're not diaphoretic. Like you're not anxious or tremulous, but you just flush. So here's what I want you to consider. In hepatic metastatic disease, when symptomatic. Okay, so carcinoids that have hepatic metastatic disease are symptomatic. Okay, the reason why is that the liver usually breaks down serotonin. If the disease is metastatic, then the patient becomes symptomatic. Okay, so one, the liver usually breaks down serotonin. I realize I phrased this confusingly, so that's why I'm numbering it. One, the liver breaks down serotonin. 2, if there's hepatic metastatic disease, you won't be able to break down serotonin. And 3, the inability to break it down causes symptomatic carcinoids. Okay. Now you also get heart failure. You can have some heart issues. We're not going to go too deep into it, but it's usually the left side of the heart that's not affected, but the right side is. So usually the left side of the heart is not affected, the right side is, and that's because the lungs, if you remember, you have your right atrium to your right ventricle, into your lungs, and then the left-sided heart, right? Then the left-sided heart. But the lungs can break down the serotonin or the carcinoid products. And I want you to stop and think, what's the precursor of 5-HT? What vitamin is also using that same precursor? And here's a hint. Deficiencies in it cause dementia, dermatitis, diarrhea, and death, the 4 Ds. So this is pellagra, and it's caused by a deficiency in niacin. That's a deficiency in niacin. And this table is just sort of showing the physiologic acid-base relationship between gastrin and secretin. So basically, um, as you get food, etc., gastrin is going to increase. So when acid falls low, it's gonna be like, oh, we don't have enough acid, and it's kind of like a negative feedback, some sort of feedback loop, because it's like, oh, when the acid is high, you're not going to get gastrin stimulation because gastrin causes the chief cells to secrete acid. When there's very high levels of acid, secretin is going to stimulate the pancreas. So notice here, acid stimulates secretin. So I'm just going to draw attention to what I want you to focus on this slide because it's busy. Decreased acid means you need more acid. So that increases gastrin. Okay? And that increasing gastrin causes acid secretion. Now, as the acid increases, that's going to cause secretin to be released to stimulate the pancreas to make bicarb and put it into the duodenal lumen. It's like, oh, we have acid coming. Let's put bicarb so we don't get an ulcer, right? To protect the duodenum from the acidic enzymes, all right, and the acids. Okay. Now, you can get tumors called gastrinomas. Gastrinomas are not found in the stomach usually, as opposed to how it sounds. I have had many medical students make that mistake. I would prefer if you didn't. So please resist the urge on an exam to suspect that a gastrinoma arises from the gastric tissue. All right, the name is misleading, but it's called a gastrinoma, not a gastroma or whatever. Okay, so the gastrinoma is usually found in the pancreas, can also be found in the duodenum. Usually multiple small tumors, but they can be solitary. All right, now because you have so much gastrin production by tissue that is not in the stomach, what you're going to get is Zollinger-Ellison syndrome. So you get peptic ulcer disease, diarrhea, acid that just does not respond to antacid treatment, and that's Zollinger-Ellison syndrome. And we're not going to go into it, but ZES is common in multiple endocrine neoplasia 1, MEN1. Okay? I'm just going to introduce this here, but we're not really going to go into it. And then GIP is the gastric inhibitory peptide. It's present mostly in the duodenum, the proximal jejunum, and it responds to meal entry. And it decreases stomach acid secretion. It's like, okay, we got the food, we don't need any more acid. And it makes the pancreas more sensitive to glucose. Okay, and it kind of enhances its response. That's why it's called an incretin. Okay, so just gastric inhibitory peptides. First of all, they inhibit the stomach. That's why they're gastric inhibitory. It's like, hey, we have enough acid. We don't need more. But they're also incretins. So they increase the sensitivity of the pancreas to glucose. That glucose sensor is enhanced. We're not going to go into it now. And it optimizes its response to glucose challenge. And then you have these GLP-1 analogs like Ozempic that have a very similar mechanism of action, but they're they're shorter lasting. Now this axis gets inhibited, gets sort of screwed up in type 2 diabetes and obesity. And then cholecystokinin, it's released in food enters the duodenum. It stimulates the gallbladder to contract, and the pancreas releases its enzymes. This is different from secretin release from the by the duodenum. So the duodenum makes secretin in response to a meal. Secretin and cholecystokinin are two different things with two different functions. Okay, don't bag them together. Although the duodenum makes both, and you can use um, the gallbladder. This you can use cholecystokinin to make the gallbladder contract, as is the name, and then you can measure how much the gallbladder ejects its stuff. And there's a diagnosis of exclusion. So when you go, when someone presents with like a biliary pattern, and we're not going to go into what that is. Fine, we will. I'm a liar. Someone presents with like right upper quadrant pain, worse after meals, blah blah blah. It looks like it looks like a biliary colic type picture, but when you go in, there's no stones, there's no gallbladder wall thickening, there's no pericholecystic fluid on ultrasound. There's a completely normal, so a negative HIDA scan is a normal. Um, so a negative, oh my God, I always mix this up. I might be wrong, so fact check me. A negative HIDA scan is a good thing because it means that the gallbladder fills normally. I could be wrong on that, but I believe in a negative HIDA scan, the gallbladder fills normally. So they'll have a negative HIDA scan, negative ultrasound, and a negative, what do you call it? Let me rephrase the HIDA scan thing. If you do the HIDA scan and you see that the gallbladder is filling with stuff, it's fine. It's not obstructed. Let's just phrase it like that for now. I'm blanking on it. But once you rule out all that other stuff, right? You do your clinical history, you get your phone, you look at everything else. There's nothing wrong with the patient. They have this consistent right upper quadrant pain that follows sort of a biliary colic picture. You can make a clinical diagnosis of exclusion called biliary dyskinesia. Now, the problem with that, using the ejection fraction for that is not all patients with a gallbladder ejection fraction less than 40% have biliary dyskinesia. So it's not sensitive or specific, and not all patients with biliary dyskinesia have a gallbladder ejection fraction less than 40%. So in other words, just because the ejection fraction is less than 40%, it doesn't mean that the patient. So let's say the GBEF is greater than 40%. That's not good for ruling out dyskinesia. Um, So that makes it a very poor sensitivity. Remember, sensitive tests are good rule out tests. Um, and then specific tests are good rule in tests because sensitive tests are so sensitive that even though you can get false positives, when you get a negative, you're pretty comfortable with it. And an ANA is a good example of that. ANA is a great sensitivity test for lupus, but anti-double-stranded DNA is more specific, which means that even though you don't get as many, you might get more false negatives with the specific test. So it might not pick up everything that's there. Um, but you can count on it that when it is positive, there's a high likelihood that what you're looking for is there. And that's specificity. So gallbladder ejection fraction is neither sensitive nor specific. So it's kind of a crappy tool that we use because we want to provide the patient with some comfort. That being said, some patients they get this procedure, they get their gallbladder taken out after biliary dyskinesia, and they're great. They're doing just fine. They stop having symptoms. Some patients don't experience an improvement in their symptoms afterwards, so it wasn't really dyskinesia. Now, in times of severe physiologic stress, like hypovolemic shock, the sympathetic nervous system can completely shut down gut function. And that's important, right? Because we talked a lot about the parasympathetic and the vagus nerve and all this hullabaloo. But let's say Timmy gets hit by a truck, right? Here's the truck. Here's Timmy. Give him a little cap with the little spinny thing on it. And Timmy gets hit by the truck. And Timmy is now in hypovolemic shock because his spleen exploded or something. So his body needs resources, and it needs ATP, and it needs to conserve its energy, and it needs to conserve its fluid. That's not really the time to be digesting and juicing. All that digestion takes energy, and all that secretion and juice formation. That's a waste of resources and a waste of liquid, and honestly, a waste of blood flow. So you'll actually decrease blood flow to the GI tract and shunt it towards more important organs. And all this is so that Timmy doesn't die. And then this kind of here just kind of shows a framework for how obesity kind of happens because you have your brain and notice that addiction executive function, so just the sheer decision to eat, or addiction to food, or food that tastes good makes us eat food. And when we eat food, we inhibit the production of ghrelin by the stomach. What does ghrelin normally do? Ghrelin normally triggers a hanginess, hungriness. So you get hanky when you don't have food in your stomach. But then when you get food in your stomach and you eat your yummy mochi, your yummy snack, the stomach now will be inhibited from making ghrelin, and that'll normalize your appetite in most people. In obesity, this whole axis gets thrown out of the picture. So you have adipose tissue, and normally leptin will inhibit ghrelin. So as the adipose tissue stores fat, it's like, we're happy. We don't need to be hungry now. In obesity, that goes out the window. The leptin, think of it like insulin resistance. It's almost like a leptin resistance, where you're no longer getting full because your body is so burned out from leptin that it's not acknowledging leptin's presence. So ghrelin goes unchecked, and you're eating. You're fat, eating, fat, leptin. Body's not responding to leptin. Who gives a shit? You're still eating ghrelin, all that stuff. All right. Um, and then you have your small intestine, and that's going to secrete cholecystokinin. Um, I don't know what PYY stands for, to be honest, and I don't care. So cholecystokinin will also basically, when the small intestine gets food, it's like, okay, we're not hungry, we have enough to work with. Eating now would be like a waste of energy or resources. We should save the food for later. Okay, and then you have some hunger hormones like orexin and neuropeptide Y. I don't know if this is like peptide. No, this is neuropeptide Y. I have no idea what PYY stands for, and I'm not going to look it up right now. So that's sort of the gamut of things. Hopefully this was useful. This was kind of like a shotgun approach to the functional anatomy of the GI tract. So if you walked away from this having a better idea of what goes on in each part of the GI tract and some of the things that can go wrong, then I would consider this a great success. I hope you have a great weekend. It is Friday as I'm recording this, or Thursday. I don't remember anymore. And I wish you guys the best.